Welcome, my name is Sharon Castellanos. My video blog will focus on gestational diabetes. This presentation is a partial fulfillment of the Biostatistics course 576 of the year 2012. My topic of discussion will be gestational diabetes. I will discuss the risks associated, the screening process, and the referral process of positive screens to Santa Clara Kaiser. I will also present a recent article published in the American Journal of Obstetrics and Gynecology, published in June of 2012, has a title of Referral to Telephonic Nurse Management Improves the Outcomes in Women with Gestational Diabetes. I am proud to say that our department played a vital role in this research study. Gestational diabetes was defined as glucose intolerance that is first diagnosed in pregnancy. It's a combination of insulin resistant, defective beta cell compensation, beta cell defect, less beta cell mass, glucanase mutation, and a blunted response to normal blood sugar fluctuations. The National Diabetes Fact Sheet of 2011 stated that gestational diabetes complicates 2 to 10% of pregnancies, and 5 to 10% are found to have diabetes immediately postpartum. And of those, there's a 35 to 60% chance of developing overt diabetes in the next 10 to 20 years following the diagnosis of gestational diabetes. Significant statistics, aren't those? Well, research associated with the risks. So what are the risks associated with the hyperglycemia in pregnancy, the high blood sugars in pregnancy? Well, research has shown that the major risk factor is macrosomia, big baby. Big baby could lead to birth trauma. Birth trauma has complications such as shoulder dystocia, difficult delivery, assisted delivery, vacuum delivery, forceps delivery. And of these deliveries, there can be significant trauma to the newborn. One of the things that we are seeing also with the macrosomia, and basically the disproportioned neonates, that where the belly is a lot larger than the head, that these babies are at risk for child and adult obesity, which predisposes them for risks of hypertension and diabetes later on in life. Other risk factors include gestational hypertension, preeclampsia, polyhydramnios, which puts a woman at risk for preterm labor, preterm delivery. That's a delivery prior to 36 completed weeks. Then the baby deals with all the prematurity risks. Neonatal respiratory distress syndrome, RDS, where the newborn has some problems breathing. Neonatal hyperinsulinemia, which can cause neonatal hypoglycemia, newborn with a lot of insulin on board once it's born, and thus puts that neonate at risk of low blood sugar within 1 to 2 hours after delivery. Neonatal hyperbilirubinemia, and cesarean delivery. And with the cesarean deliveries, there's risk for mom are anesthesia, infection, bleeding, longer time in the hospital, but also with these deliveries on these macrosomic disproportion babies, the risks do increase. So what's the screening process for gestational diabetes? Well, what is used is the Carpenter-Kustan's criteria, in that normal blood sugar values post 100-gram load are fasting blood sugars less than 95, 1 hour less than 180, 2 hour less than 155, and a 3 hour less than 140. If women have 2 or more blood glucose values higher than that parameter, they are given the diagnosis of gestational diabetes. Another way a woman is screened for gestational diabetes that shows a positive screen for gestational diabetes is on the 1 hour 50-gram glucola. If a woman has a test equal or greater to 180 and is therefore contacted and told to have a fasting blood sugar, and if that fasting blood sugar is greater or equal to 95, that woman does have the diagnosis of gestational diabetes. We stop there. We do not need to give her that 100-gram load because she's met that criteria for gestational diabetes. So who are screened? Well, high-risk women are screened in the first trimester or as soon as they would come in and we find that they are pregnant. Who are the high-risk women? Well, women that have had a previous history of gestational diabetes, first-degree relative with diabetes, multiple gestation, twins, triplets, quads, and women that are morbidly obese. Low-risk women, all the other women, are screened between 24 to 28 weeks. Now, women that we do not screen with the glucola sugar challenge test are women that have had post-bariatric surgery, bypass surgery. These women, we do not recommend that they have a glucola screening. And the reason for it leads to dumping syndrome. So how are these women, how do we diagnose these women if they have, in regards to gestational diabetes? Well, women that have had a gastric bypass, these women are referred to our dietitian, and they are given a diet in which to follow. These women are also taught home glucose monitoring, and they are testing fasting and 1 hour postprandials. If they have a fasting greater than 90 and a 1 hour postprandial greater than 130 on 2 or more occasions, they are given the diagnosis of gestational diabetes. And they follow the same process that our women do with routine screening for gestational diabetes. So what do we do at Santa Clara? Well, in the past 4 years, we have noticed there's been a significant rise in women in our obstetrical patients at that site. And with this steady rise, there's been an increase in women diagnosed with gestational diabetes. Last year, in the year 2011, there was a total of 4,141 deliveries, and of those women, 427 were diagnosed with gestational diabetes. That's a total of 10.3% of the population. That's a significant amount of women that are developing gestational diabetes. So how do we meet the needs of these women within our Department of Perinatology? Well, using Roy's adaptation model to guide our practice, we developed an understanding of the content, what we were looking at, what was our goals. We reviewed existing research and practice models in the area in regards to meeting the needs of our members that develop gestational diabetes. We constructed a conceptual, theoretical, empirical structure in regards to this need. So what did we come up with? Well, we came up with the referral to the gestational diabetes group visit. And this group visit, all English-speaking pregnant women that were screened positive were referred to this group visit. Each patient that was referred was also referred to the telephonic nurse management program. Each patient also received an evaluation form pre and post tests, and also looked at the patient's perceptions to see if the needs were met, if her needs were met. What did the group visit consist of? It was a total of 3 consultations. It included a maternal fetal medicine nurse practitioner in the first hour, and what she did is discuss with the members what is gestational diabetes, what are the risks during the pregnancy, delivery, and future risks for mom and baby. But there is a main emphasis placed on preventative and how this woman can prevent the risks to both her and her offspring. The second hour was given by a registered nurse, staff nurse 3, where she instructed the members how to do the blood sugar monitoring, how to check their blood sugar, how to interpret those numbers, and talked about the telephonic nurse service that we had. And this service is available to our members 24/7. The third hour is with the registered dietitian. She's also a certified diabetic educator, and what she would do is talk about the gestational diabetic diet. And what she also did is looked at the demographics in our group. And what I mean by that is that here in Santa Clara County, we have a diversity of cultures. And so she would look at that and discuss certain meals and certain foods, and she would tailor that depending upon the members that were in that group visit at that time. So she would she does tailor each group visit in regards to what her recommendations are in regards to dietary, which is amazing. In this group visit, there can be anywhere from 1 to 14 women. So the referral to the telephonic nurse management in regards to improving outcomes in women with gestational diabetes. Well, this research study is a quasi-experimental design. It looked at the association between referrals and outcomes. It looked at the effect of the telephonic nurse management on women with gestational diabetes. So what's the purpose of the study? Well, the purpose of the study was to educate medical personnel that close monitoring can improve outcomes for women with gestational diabetes, the preventative health care effects of this, and it's a less expensive model for providing care. The cohort population consisted of women diagnosed with gestational diabetes according to the National Diabetes Data Group criteria, who delivered between January the 1st of 1997 through December the 31st of 2006. A total of 11,435 women were identified from 12 Kaiser Medical Centers, of which 44.5% were referred to the perinatal nursing services. Each medical center was categorized by center referrals, less than 30%, 30 to 70%, or greater than 70% for each year. A chi test and the odds ratio were used to look at the differences in women's clinical characteristics by their referrals. The covariates that were included were age, race, ethnicity, BMI, education, uses of medicine, and the 3-hour glucose test. And here is that table that goes over that, as you could see. So what was the conclusion of this research study? Well, this quasi-experimental design had adequate samples of patient enrollments, infant outcomes, and postpartum follow-up. This study concluded that women with gestational diabetes with a higher referral rate to the telephonic nurse management centers was associated with decreased risk of macrosomia and an increased risk of postpartum glucose testing, with adjusted odds ratio of 0.75, 95% confidence interval, at 0.57 to 0.98, and in a multiple adjusted odds ratio of 22.96 with a 95% confidence interval, and a 2.56 to a 3.42 respectively. Care received at centers with high referral rates to telephonic nurse management center was associated with decreased risk of macrosomic infants and increased postpartum testing. So what impact does Santa Clara group visit for women diagnosed with gestational diabetes have to come into play in regards to this research study? Well, Santa Clara Homestead and the Satellites Clinic have a greater than 70% referral to the nurse phone management program. And of our members that do come into our group visit, greater than 70% of these women follow up with postpartum diabetes testing, compared to less than 20% of the general public. Those are amazing outcomes. One that our department is very proud of. Women diagnosed with gestational diabetes are offered an appointment in less than 7 days from diagnosis. As you could see, there was a large number of women that have been diagnosed with gestational diabetes within our service population, and in a way that we were able to meet these needs to get these women in less than 7 calendar days, that's including the weekends. We needed to come up with some type of model to meet their needs, and that is where we came up with the group visit in regards to gestational diabetes. So what are the future implications to this practice? Well, we are now looking at using the same application model, the group visit, and applying it to our women for preconceptual counseling. For example, women with metabolic syndrome, mild hypertension, and obesity. And with the emphasis placed on this, the emphasis on prevention. In conclusion, I cannot speak on how important preventative health is. Let's begin with our youngest, and those are the fetus. This ends my presentation. Thank you for your time and feedback. Happy holidays.